A very good evening to all these students who are joining this session. So, exam is just around the corner. So, I think we are live. So, we can start with the session. Remaining videos will be uploaded. I think most of the videos are done. Revision videos, whatever extra we had to do, they have been done. The remaining videos which will be up, they are basically just edited versions of the existing videos only. Already the content is about 300 hours, and so I don't think there is any scope for adding more thing. At the same time, there will be some update videos which will keep on happening, but it is unrelated to the upcoming super specialty exam. And this revision sessions that we are doing right now live, these are the ones where I'm going to cover and tackle some of the one-liners and some points which you all requested. These are vaccine-related updates and thalassemias and some new monoclonal antibodies, gene therapy one-liners, the additional things that I will be taking up in the next LRR session, which will be coming up tomorrow. So with this in mind, let us start with the session. And here my focus is going to be on the genetics part, syndrome part. So I will be tackling with syndrome, every NEET super specialty exam. Let me tell you first of all, the facts, the basis of why we have taken syndromes today. NEET super specialty 2021, there were 6 questions on syndromes. 2022, there were 4 questions on syndrome. 2023, there were 7 questions on syndrome. And 24 has not happened. 24 is happening in 25. So you people will be telling me, there has been direct or indirect 1 question on the trisomies, the typical 21, 18, 13. There has been 1 question on Turner syndrome, Klinefelter-Noonan, the second most important syndromes among the syndromes. And one of the favorite of examiners have been your Williams syndrome, as well as, if you remember, those who have given the exam previously, there were 2 questions of Williams syndrome, not 1, 2 questions of Williams syndrome asked in 2023 NEET SS exam. One was a direct one-liner case, and one was a case scenario where Elfin facies was the catchword. And Alagille syndrome again has been asked in 2022 also and 2023 also. So what we are going to do is we are going to tackle all of them. We are going to do all the key revision one-liners. I will not go into the unnecessary pathogenesis things, but it will be a useful collection of topics for you. And for those who have messaged me already 3-4 minutes back, कि sir और क्या क्या हम करेंगे, tomorrow I am going to take up. So if you want me to take up 5 minute summary, don't overburden it. But I'll tell you what I'm going to take up tomorrow. Tomorrow, I'm going to take up named procedures and one-liners on cardiology. I'm going to take up some one-liners and topics, atypical topics in neurology, thalassemias, brief summary, key points, including the gene therapy update. I am going to take up, Equathotum, I will take Soto syndrome and Bardet-Moon-Biedl syndrome also tomorrow, because I don't think we have scope here. I'm already going to discuss about 20 syndromes today. So whatever syndromes are left, I will be discussing them tomorrow, right? So let's join tomorrow. Let us start with the syndromes discussion directly. And of course, it makes sense to start with the star player of syndromes, the evergreen, ever important Down syndrome today. Now, what is Down syndrome? Down syndrome, you all know. Why do I say it is Down syndrome? Have a look at the picture. You can see that this is a child who's having the typical dysmorphic face. When you talk about dysmorphic face, we tend to think about that the child is having a mongoloid slant. No, not the mongoloid slant. Mongoloid slant can be seen in normal people also. But it is the flat nasal bridge, open mouth with protruded tongue, and a combination of features which is relevant for the clinical diagnosis of Down syndrome. So what are the key points you can see? Well, let us label it first of all. This is a child who's having the typical facial dysmorphism. So first thing you can see in the patient is facial dysmorphism. Second thing you can see in this panel of images, if you can see this child is having this single transverse palmar crease, what you call as the simian crease. Thirdly, you can see the last finger is shortened and curved inwards. This is clinodactyly. And then you have the increased gap between first and second toe, what you call as the sandal gap. So because there is a spectrum of these disorders, so likely the child is suffering from Down syndrome. First thing about Down syndrome, two one-liners to note. First of all, Down syndrome is the most common. Down syndrome, am I visible here in the screen? Yes. Down syndrome is the most common. Let me increase the size of the font also, so it is easier for you to see. It is the most common genetic cause. Down syndrome is the most common genetic cause of low IQ or global developmental delay in children. In fact, I have discussed about global developmental delay key points very recently. And if you look at the IAP 23 guidelines, they say that Down syndrome trisomy 21 is among the most common causes of global developmental delay in children below 5 years in India. They have mentioned the Indian data and they say genetic cause, most common cause, it is Down syndrome, that is trisomy 21 they have mentioned. Right. So this is first thing, that is most common genetic cause of low IQ in children. Down syndrome, what is the mechanism? We all know that the mechanism of Down syndrome involves three varieties. 90 to 95% cases, it occurs due to trisomy 21. Trisomy 21 occurs because of maternal non-disjunction of chromosomes. There is maternal non-disjunction of chromosomes during meiosis. So during meiosis, the maternal set of chromosomes do not separate and one of the ovum carries two copies instead of a single copy of chromosome 21. Then the sperm fuses with it, brings its third copy, and so now you have a true trisomy getting created. So true trisomy getting created, that is trisomy 21. It is responsible in 90 to 95% cases. Trisomy 21, this maternal non-disjunction of chromosome is associated with advanced maternal age. So this is the one which is associated with advanced maternal age. Now you all know that it is the advanced maternal age which is responsible for producing Down syndrome. Paternal age has no correlation with the increased likelihood of developing Down syndrome. So remember, it is advanced maternal age which is associated. What is the risk according to the age of the mother? Percentages and prevalence ratios are asked in the exam. They have already been asked in INI super specialty. I'm not boasting, but I have discussed one table in the regular videos from where direct question was asked in INI super specialty exam, second half 2022. It was asked directly over there. So that table I'm going to quickly revise with all of you. So on one side, you would write the maternal age, and other side you would write the risk of developing Down. So if the maternal age is between 15 to 29 years, the risk of Down syndrome is 1:1550. So risk is relatively low. In case the maternal age is 30 to 34 years, the risk becomes 1:800. If the maternal age is between 35 to 39 years, the ratio becomes 1:270. If it is 36 to 40 years, 35 to 39, then you have 40 to 45 years. 40 to 45 years, the ratio becomes 1:100. And if it is more than 45 years, the risk becomes 1:50. I'm putting it in a bracket. This has been asked before in INI super specialty, so can be asked in NEET super specialty exam as well. Most of the things about Down syndrome you might be knowing, but accuracy is what you need if you get a question like this for the exam, in your exam. So this is the association of advanced maternal age with Down syndrome. Not a part, but because we are doing a comprehensive revision, so I want to discuss a very interesting thing with you. Can you name any syndrome associated with advanced paternal age? There are many, but the one I'm writing has one of the strongest association, which is mentioned in many textbooks, including Nelson also. Name the syndrome associated with advanced paternal age. It's a very popular syndrome. If you don't remember, it's a potential MCQ point. There is a syndrome known as Apert syndrome. Klinefelter has been proposed, but the evidence has been lacking. It is Apert syndrome. Do you remember Apert syndrome? Apert syndrome, we will discuss briefly today. Apert syndrome is a type of craniosynostosis related syndrome. And in this patient, you have the typical midface hypoplasia, you have brachycephaly, and you have those mitten hands. That one is associated with paternal age. So put a star, remember it, don't forget it. Because we talked about maternal age, so we are talking about it here as well. So apart from Ipert, yes, aquathotum is absolutely right. There are others like Prader-Willi, which have also been associated. Prader-Willi has also been associated, right? But Nelson clearly mentions at two places in the chapter on craniosynostosis and also in genetics about Ipert, and so on the agenda, on the radar of examiner. So the first mechanism of Down syndrome, the first mechanism, as I said, it is 90 to 95% cases, it is trisomy 21. But it is not always trisomy 21. The second mechanism, in 4% cases, Down syndrome occurs due to translocations, what we call as Robertsonian translocation. You all know what Robertsonian translocations are, so I will not go into the details. These Robertsonian translocations involve chromosome number 21. There are three important types of Robertsonian translocations which have been described. We have translocation 1421, we have translocation 1521, and we have translocation 2121. Out of them, translocation 1421 is relatively common among the translocations involving Down syndrome. If the mother, if there is a maternal carrier, if mother is the carrier of this translocation, the next generation child having risk of Down syndrome is 10 to 15%. So 10 to 15% risk of Down syndrome is in the offspring. If it is a paternal carrier, then the risk is about 3 to 5%. So remember, here also, if mother is the carrier of translocation, the risk is relatively high. Translocation 1521 risk, it is relatively rare, not described. The rarest among them is translocation 2121, but the important thing is there is a 100% risk of developing Down syndrome. So which translocation has a 100% risk of developing Down syndrome? It is translocation 2121. And then about 1% cases, Down syndrome will occur due to mosaicism. So you will have mosaicism producing Down syndrome in the patient, right? So these are the genetic basis. Just as a one-liner you can write, although it is no longer useful in the diagnosis, that Hall's diagnostic criteria, there are 10 criteria. Hall's 10 criteria was used previously for Down syndrome diagnosis. So Hall's 10 criteria was used previously in Down syndrome. Let us focus on the key points. Key features of Down syndrome that we need to remember. What are the key features of Down syndrome? Let us do a quick fire revision. First of all, we'll start from the top and go down. First of all, you have the craniofacial features. I will not write everything, only the relevant points I will be writing. Craniofacial features. Down syndrome children have an abnormal skull shape. These children are having brachycephaly. What is brachycephaly? Brachycephaly is a condition in which there is bilateral coronal suture premature fusion. So whenever there is premature fusion of bilateral coronal suture, also called as bicoronal fusion, the brachycephaly, a flattened skull is produced. In a brachycephalic patient, remember that the patient is having increased biparietal diameter, but there is reduced anteroposterior diameter. This is the feature of brachycephaly that you see in the patient. Secondly, these patients will be having delayed, second feature, they will have delayed closure of anterior fontanelle. Third, these patients will have mongoloid slant of eyes. Although the word mongoloid is avoided these days due to racial issues, but mongoloid slant of eyes is also called as upward slanting of eyes. Upward slanting of eyes. Whenever we talk about slant, remember that we start from the medial side and go to the lateral side. So there is an upward slanting of the eyes. So this is the typical mongoloid slant of eyes, right? Lateral canthus at a higher angle than medial canthus is the upward slanting of eyes. When they say downward slanting of eyes, that is anti-mongoloid slant typically seen in patients with Noonan syndrome. It can also occur in Treacher-Collins and other syndromes as well. Then these patients will have an open mouth with protruded tongue. These patients will have low set ears. They have flat nasal bridge. And the ear which are present, they are not normal. The ear are often found to be dysplastic as well. So these are the first thing, that is craniofacial features which are important. Second feature, second component is the neck of the child. And you find that the neck is short, it is non-webbed, it is non-webbed, and there is increased risk of developing atlantoaxial instability. What is atlantoaxial instability? The atlas axis joint is unstable in Down syndrome patient. First vertebra and second vertebra, their joining with each other is not proper, and the supporting ligaments and tendons are missing, leading to higher risk of developing cervical spine injury even with trivial trauma. And that is the reason why contact sports is avoided in a patient of Down syndrome. What is the reason why they're avoided? Atlantoaxial instability. This is increasing the risk of cervical spine injury. So there is also a question you can get in the exam. A Down syndrome patient undergoes road traffic accident. Which early thing should be done after airway breathing circulation? Put a cervical collar, immobilize the cervical region because of high risk of cervical spine injury. According to various textbooks, the atlantoaxial instability is found in 10 to 30% patients of Down syndrome. So up to every third Down syndrome child will have atlantoaxial instability. And that is why any trauma to the Down syndrome child always get a lateral view of cervical spine done. So lateral view cervical spine of the neck, that is very, very important in the neck. Third thing, you will have the limbs. In the limbs, the Down syndrome child will have features like, I have already told you, single transverse palmar crease called as simian crease. There will be clinodactyly. The Down syndrome children, the hands are anyways short and stubby, and these children have sandal gap in the toes. So sandal gap will be present in the toes. Fourth feature, Down syndrome patients will have, plus there is a high risk of developing, SCFE also. SCFE means slipped capital femoral epiphysis risk is seen. It is high. It is 2 to 3 times the normal children. So slipped capital femoral epiphysis risk is increased. Fourthly, you will have the systemic problems occurring in Down syndrome. Let us do a rapid fire review. What is the most common congenital heart disease? You all know it is endocardial cushion defect, also called as complete atrioventricular canal defect, followed by VSD, followed by ASD. Endocardial cushion defect typically shows abnormality. What is the abnormality associated with it called as? It is also called, it produces a deformity known as goose neck deformity. And goose neck deformity is another one-liner super specialty MCQ of the past. On angiography, goose neck deformity is seen in which congenital heart disease? Endocardial cushion defects. Then second thing, what is the most common GIT malformation? The most common GIT malformation is duodenal atresia. Duodenal atresia is the most common GI malformation, followed by Hirschsprung disease in the patient. Followed by Hirschsprung disease. Thirdly, we look at the most common ocular manifestation. Let us look at the eyes of the child. There are two types of abnormalities. One abnormality which does not affect the vision. So vision not affected. And second abnormality which affects vision. So vision is affected. Which is the most common abnormality but which does not affect vision in Down syndrome child? That is brush field spots in eyes. They do not interfere with vision. Plus, some children can have nystagmus also. However, the conditions which affect vision in the child, they are strabismus and myopia. In fact, myopia of some degree is present in 40 to 50% patients. However, not every Down syndrome child will require lenses, and it is a high myopia but fluctuating in the first 10 years. That is a typical thing found in Down syndrome. Then these patients will have ear abnormalities, and you will find that hearing loss, conductive hearing loss is seen in 40 to 60% of the patients. These percentages which I'm writing are relevant. And why does conductive hearing loss occur? It occurs because of serous otitis media. I'm highlighting it again. It's a past MCQ point. Serous otitis media is the reason why Down syndrome children have increased risk of hearing loss. Then these children can have other abnormalities. They can have hear abnormalities. They will have increased risk of alopecia. They have increased risk of premature graying of the hair. Down syndrome children will be having obesity and undescended testes. The risk of undescended testes, if it is a male child, that is increased. Then thyroid disorders are common. Hypothyroidism. Hypothyroidism is found in 1/3 of the patients. So almost 30% patients have Down syndrome, and males are often found to be infertile. Infertility can occur in both males and females, but infertility is more commonly seen in males compared to females. Then Down syndrome children can also have obviously CNS abnormality in the form of low IQ. They have high risk of developing early onset Alzheimer's disease. And why does early onset Alzheimer's disease occur in Down syndrome children? Because the gene for this is carried on. APP gene is present on chromosome number 21. And because there are 3 copies of chromosome 21, early onset Alzheimer's disease is very common. Apart from that, other neuropsychiatric manifestations are also commonly seen in Down syndrome. And then you have the hematological abnormalities seen in Down syndrome. What are the hematological abnormality? There is increased risk of developing leukemias. Leukemia risk is high. Leukemia risk, generally it is seen that most common leukemia is ALL, whereas the most specific leukemia found in Down syndrome is AML. According to FAB classification, it is M7 FAB classification. Apart from that, these children also have increased risk of developing transient leukemia. Some of them can convert into AML in later life, or there can be a progressive transformation. Transient leukemia was previously called as transient myeloproliferative disorder, but that word is avoided these days. And transient leukemia risk is specifically associated with GATA gene mutations. GATA gene mutations have a higher risk of transient leukemia. This is your NEET super specialty MCQ. GATA gene mutations in Down syndrome are significantly increase the risk of developing transient leukemias in the patient. Right? Transient leukemias in the patient. Chabi Thakur is asking which syndrome is most commonly associated with CHD. Obviously, Chabi, it is Down syndrome. It is not Mona. It is Down syndrome. And then finally, there is increased risk of developing juvenile idiopathic arthritis in later life. And also remember that the life expectancy of Down syndrome patient is roughly about 50 to 55 years. But it is highly variable across the population and also depends upon how many comorbidities are present. Every Down syndrome child will not have all of these problems. That is also you need to understand. Now, there is a very, very important thing I'm highlighting here, which is discussed in Nelson also. What is protective or negative association seen in Down syndrome? Protective or negative association in Down syndrome. What do we mean by protective or negative association in Down syndrome? Certain disorders are less common in Down syndrome compared to general population. First of all, solid pediatric tumors are less commonly seen in Down syndrome. So what are the solid pediatric tumors? Example, neuroblastoma, Wilms tumor, etc. are not seen. Leukemia risk is high, but solid pediatric tumors do not occur. Second, increased risk of ischemic heart disease is not seen. In fact, Down syndrome children, despite being obese, many of them having hyperlipidemia also, are protected against ischemic heart disease. So they do not develop ischemic heart disease. So if someone says a Down syndrome patient has a Down syndrome patient, 40-year-old, was obese and found to be dead, autopsy revealed MI in Down syndrome. Would you trust that autopsy? No. Probably the person was murdered, right? You can make a small crime thriller out of it. And obviously not in India. You need to have that kind of a system also, because putting a item song in such a movie will be difficult. But I know it's a stupid example, but you can well imagine like this, that a rich person had a child had a only son with Down syndrome, died. It was said he died due to MI. The father suspected that it was not MI, it was something else. And why did the father think so? Because he has read Nelson, he has appeared in super specialty exam, he's a pediatrician, and he knows that Down syndrome does not develop ischemic heart disease. I know stupid way, but you will remember stupid things better. And third, they have a less risk of developing adult onset epithelial tumors. So adult onset epithelial tumors are less commonly seen in Down syndrome. Yes, it is the Down syndrome day. Yes, it is the Down syndrome day, right? So these are the conditions which are less prevalent seen in Down syndrome. Moving further to the screening that you need to do in Down syndrome. So this is something that you need to remember. For the purpose of CHD, when do you do screening? The screening should be done within 4 weeks of birth. Some books say it should be done at the time of birth, but generally, practically, it should be done within 4 weeks of birth. That is, in the newborn period itself, you should do screening for congenital heart disease. What about vision testing? Ophthalmic evaluation should be done ideally at birth. It should ideally be done at birth and must be done within 6 months if delayed. And then they require annual screening. In a Down syndrome, if there is no congenital heart disease detected initially, you don't need to do any annual examination. But for vision testing, sometimes myopias can manifest later, and you need to do annual examination in these patients. This screening pattern is very important, and I'm putting stars. This is something which, being an examiner, it will be, if I'm an examiner, I will be putting something out of it because it has practical implications for you. Then for the hearing loss, you have to do the autoacoustic emission. Autoacoustic emission, and use a different color pen. Autoacoustic emission should be done within 3 months of birth. Then you should do hearing evaluation. You should do ENT consultation. You should do an ENT consultation every 6 months till 3 years of age. Particularly if the tympanic membrane visualization is not proper, because up to 3 years, first 3 to 4 years of life, the chances of serous otitis media is maximum in the patient. Then is growth assessment. In the first year of life, you should be doing it twice. That is 6 monthly. And then second year onwards, you will start doing annual. What about thyroid screen? Thyroid screen should be done in the patient first at birth, then between 6 to 12 months, and then you should be doing annual. As for celiac disease, the first testing for celiac disease, the TTGA test, IgA TTGA test should be done at 2 years of age, and then anytime if sign and symptoms appear. If sign and symptoms appear. For atlantoaxial instability, you should get a lateral view X-ray. I'm writing below here. Lateral view neck X-ray, including the cervical spine, between 3 to 5 years of age. Before that, the chances of even the neck is shorter, and the child is anyways not going to go into some contact sport. So between 3 to 5 years, it should be done. And then you should do it only if indicated. Repeated X-ray is not indicated, and the child should avoid contact sports under every circumstance, right? So this is the one regarding, these are the key points regarding Down syndrome. We have spent a lot of time on Down syndrome. Let us move towards the other syndromes. They also demand some attention. The second one is your Edward syndrome. Edward syndrome, what is the genetic problem? Trisomy 18. Trisomy 18. Edward syndrome is also associated with advanced maternal age. But similar table is not applicable here, neither is it available. So which is the other trisomy which is associated with advanced maternal age? It is Edward syndrome. What are the key features? What are the key features that you need to remember in Edward syndrome? First of all, Edward syndrome patients will be having a microcephaly, small head, but this microcephaly will be having a prominent occiput. They have a prominent or pointed occiput. Second, they will be having overlapping digits. Look at the hands of the child. Can you see the digits are overlapping? Both in the neutral position, in a resting position. Normally, our hand is like this, but Edward syndrome child, there will be overlapping digits which will be present. So, overlapping digits is a key feature. Thirdly, they will have tight palpebral fissure, and many of times they will be unable to open their eyes, according to Nelson. So, tight palpebral fissures is often found with or without microphthalmia. Microphthalmia means a small eye that may or may not be present, but tight ophthalmic fissure is common. Fourthly, they have increased risk of developing anterior abdominal wall defects. What are anterior abdominal wall defects? You know, omphalocele, gastroschisis. Both of them are relatively common in Edward syndrome compared to general population. Fifth, they have an orthopedic defect called as rocker bottom feet. Rocker bottom feet is found in more than 80% of the patients of Edward syndrome. The arches are not only flat, the arches are actually concave. That type of orthopedic deformity is called as rocker bottom feet. Rocker bottom feet can be congenital, it can be acquired. Congenital one occurs in Edward syndrome, rarely occurs in Patau syndrome. The acquired one occurs as a complication of overcorrection of clubfoot, also called as CTEB. So rocker bottom feet can be present in the patient. These children will also be having a small jaw called as micronathia. They will have a small jaw called as micronathia, and they will have hypoplastic nails. Hypoplastic nails with short sternum. And finally, they have increased risk of developing congenital heart disease. Which is the common congenital heart disease? It is VSD followed by ASD. It is VSD followed by ASD. Remember that the apparent, whenever Edward syndrome children will have a median survival less than, their survival is less than 3 months. Their general survival is less than 3 months. And there is a very unique thing which is mentioned about them, that they will have narrow pelvis. They will have narrow pelvis with limitation of abduction. Narrow pelvis with limitation of abduction. And so sometimes they can be diagnosed by neonatal hip examination. Sometimes neonatal hip examination can help in identifying patients of Edward syndrome. In one of the quizzes, IAP quiz, zonal level, this was the question asked in the exam. So one of the students actually asked me, and to be honest, even I was, I had no idea. I knew about the thing, but sometimes you need options or you need a very characteristic thing. It also took me about 5-10 minutes. I said, okay, I will see and search. And about 10 minutes later, suddenly it struck me, oh, Edward syndrome has narrow limitation of abduction and narrow pelvis. So which trisomy can be diagnosed by neonatal hip examination was the question. So this was the answer, that is Edward syndrome. Now it looks easy. In fact, I have taught this in my class also, in my video lecture also. But somebody asks you directly, unless options are there, sometimes things do not strike them. So this is something that you can highlight somewhere and add to your notes. Then we come to the third one, Patau syndrome. You can have a look at the picture. What are the characteristic things you can see in this child? Can you see this child is having the typical cleft lip and cleft palate, and he's also having polydactyly. So remember, overlapping digits, Edward syndrome, multiple digits, Patau syndrome. So what is the genotype in Patau syndrome? What is the trisomy? Patau syndrome is trisomy 13. And this is a one syndrome which is not associated with advanced maternal age. Down is associated, Edward is associated, Patau syndrome is not associated with advanced maternal age. So what are the key features that you need to remember regarding Patau syndrome? So what are the key points that you need to remember? First of all, these children will have microcephaly. And when you do MRI of the brain, you will find a unique finding. You will find a characteristic thing called as holoprosencephaly. It's a migration defect in which the two cerebral hemispheres fail to separate. There is a single cerebral hemisphere, there is a single ventricle instead of two lateral ventricle, and there is absent corpus callosum. And extreme form of it, There will be a small microcephaly with single eye in the center. This is what you call as the cyclops appearance, which is not compatible with life. That is a even severe, more severe and rare form of Patau syndrome. So just remember, MRI finding hollow present cephaly is a very characteristic thing found in patient of Patau syndrome. What are the other features? Let us do a quick rapid fire review. I'm writing it here. They will have polydactyly. What kind of polydactyly is seen? It is post-axial polydactyly. What is post-axial? It means the extra digit, as you can see in the image, it will be present on the ulnar border. Feet also, it will occur on the outside. Thirdly, these patients will have congenital heart disease, which is VSD followed by ASD. Fourthly, they will have ectodermal scalp defects. Dr. Brain PDF of this will be posted in the comment section after about 2 to 3 hours after the class is over. So tonight itself, by midnight, you will get this PDF. For now, just focus on listening. So ectodermal scalp defects can be there. Some patients can have aplasia cutis. Segments of skin, the epidermis of the skin will not form. We call it as aplasia cutis. Sixth feature, I'm writing it below. Sixth feature, there is increased risk of developing PHPV. What is PHPV? Persistent hyperplastic primary vitreous. The vitreous humor that we have is the secondary vitreous. Initially, there is a fetal vitreous called as primary vitreous, which is absorbed. But in Patau syndrome patients, there is abnormal persistence of that. So persistent hyperplastic primary vitreous. Seventh thing, I'm writing with a different colored pen, very characteristic, they have missing or hypoplastic ribs. And so one of the older names of Patau syndrome is also missing rib syndrome. So which condition is characterized as missing rib syndrome? Unless you have read it recently, you might just not recall it in the exam. Missing rib syndrome is nothing but Patau syndrome. Eighth feature, they will have hyperconvex nails and they will have abnormal dermatoglyphics. Means their fingerprint pattern is bizarre. It does not follow the normal pattern that we see. And then what is the most characteristic feature on the face that you will see? These patients will be having a cleft lip and cleft palate. But remember, there can be Patau syndrome patients without this also. But the most characteristic feature will be cleft lip and cleft palate in the child. So this is regarding Patau syndrome. Their median survival is even less than Edwards syndrome. It is less than 1 month. So survival in these patients is even less. Can rocker bottom feet occur in Patau syndrome? Yes, but the chances are more for Edwards syndrome. Then we come to the next syndrome, Alagille syndrome. Alagille syndrome has been asked 2 times in NEET super specialty exam. 2022 question was asked, 2023 question was asked. 24 is going to be held in 25. You will tell if a hat trick is made or not, right? So we have no idea, but we'll still try to remember the keywords. As you can see the face of this child, it's a triangular face condition with the liver involvement, that is hepatobiliary, eye involvement, and some other organ systems involvement. Now, few points about Alagille syndrome. What is the gene mutation found in Alagille syndrome? So the most common genetic mutation, most common gene mutation in the patient is JAGD1 gene. JAGD1 gene. JAGD1 gene found on chromosome 20p. Second most common gene mutation associated with Alagille syndrome is Notch2 mutation. The gene is present on chromosome 1p, right? So short arm of chromosome 1. Now, Alagille syndrome, what are the key points that you should remember? The most common mode of inheritance, it is autosomal dominant inheritance, which is C. What are the key features? Key features that you need to know. First of all, these patients will be having a abnormal triangular face. They have a underdeveloped mandible and a sloping forehead with deep set eyes. So abnormal triangular face with deep set eyes. Second, these patients will have vertebral abnormalities. What is the typical vertebral abnormality? You will find butterfly vertebra. Butterfly vertebra. However, some patients do not have butterfly vertebra. They can have hemivertebra. So vertebral abnormalities are common. Third, these patients will be having increased risk of developing congenital heart disease. Which is the most common congenital heart disease is one of your NEET super specialty MCQ. It is peripheral pulmonary artery stenosis. Second common is pulmonary. It is also sometimes written as pulmonary artery hypoplasia. Second common after that is pulmonary valvular stenosis. Pulmonary valvular stenosis. And then you have tetralogy of Fallot and the other septal defects coming. Fourth, Alagille syndrome children have increased risk of developing jaundice. And jaundice occurs due to paucity of bile ducts. It is acquired paucity of bile ducts, progressive paucity of bile ducts, and so the type of jaundice in the patient is conjugated hyperbilirubinemia. So neonatal cholestasis, one of the reason is Alagille syndrome. And fifth involvement is eye involvement. Eye involvement occurs in the form of microcornea. There is a small cornea. And there is a thing called as posterior, I'm writing with a different colored pen, posterior embryotoxon. These children have posterior embryotoxon. What is posterior embryotoxon? There is a ring-shaped structure. It is a ring-like structure due to prominent Schwalbe's line. Due to prominent Schwalbe's line. Treatment in the patient, of course, is supportive, but some of these patients, about 50% of these patients are found to have xanthomas due to hypercholesterolemia also. So xanthomas develop in more than 50% of these patients. So all the key points I have highlighted in one place, that is Alagille syndrome for you. Moving over, we have the next syndrome called as Cornelia de Lange syndrome. Again, an important topic. And you can have a look at the face of this child. The characteristic face in the child is joining of the two eyebrows. So joining of the two eyebrows, also called as synophrys, is a characteristic feature. First of all, Cornelia de Lange syndrome, what is the gene? The gene is found on chromosome number 5. The genetic basis of Cornelia de Lange syndrome is NIPBL gene present on chromosome number 5. Present on chromosome number 5. What are the features, key features of Cornelia de Lange syndrome? First of all, they have a facial dysmorphism, so they will have synophrys. What is synophrys? Bushy eyebrows joining in the center of the forehead. Joining in the center of the forehead. Can occur in normal children and normal adults also, but it is a very characteristic feature facially of Cornelia de Lange syndrome. Secondly, you look at their philtrum. Can you see there is a smooth and wide philtrum? Smooth and wide philtrum. Third thing, look at their nose. There is a upturning of the nasal tip. It's bulbous and it is upturned. And fourthly, there is a short, thin upper lip. Short, thin upper lip. There is a short, thin upper lip. And fifth, when the child tries to speak, the sides tend to go down. On speaking, the sides of the mouth tend to go down. Go downwards. These patients have other abnormalities, including increased risk of developing congenital heart disease. Which congenital heart disease can occur? VSD is relatively common, is the most common congenital heart disease seen in Cornelia de Lange syndrome. Apart from that, they can also have low IQ and neurobehavioral problems. Moving further, we have this syndrome called as Rubinstein-Taybi syndrome. Rubinstein-Taybi syndrome typically occurs due to CREB-BP, CREB binding protein gene involvement on chromosome 16p. And it is also considered to be a type of microdeletion syndrome. The most characteristic thing, as you can see in the photograph, these children are having abnormal, thick, broad thumbs, as well as abnormally thick, broad toes, right? So abnormal, thick, broad toes. The hallmark of Rubinstein-Taybi syndrome is abnormally thick, and broad thumbs and toes. So if you find a photograph like this or a patient like this, you should think of. Apart from that, they will also have some degree of facial dysmorphism. Then you have this Williams syndrome, because it's already going to be 9. So I'm just picking up pace without compromising on the most important key points. Williams syndrome, again, 2 times asked in the super specialty exam. Last time, as I said, there were 2022-23 exam, there were 2 questions on Williams syndrome. So first of all, it occurs due to ELN gene mutation on chromosome number 7q. ELN codes for elastin protein. So elastin gene mutations are responsible for producing Williams syndrome. What are the key features? You already know the key features. These patients are having alpine facies. They have alpine facies. Secondly, they have low IQ. Third, they have developmental delay. You can write like this. They have low IQ and developmental delay. They will have, what is alpine facies? Elf-like face, blue eyes, upturned nose, rounded face, curly hair, and wide oral aperture with pointed teeth. That is called as alpine facies. Thirdly, these children will have congenital heart disease. The most common congenital heart disease is supravalvular aortic stenosis. This was one of the MCQ asked in NEET Super Specialty 2023. Fourthly, these children will be having hypertension, and when you check their blood, you find that they are having hypercalcemia. Hypercalcemia is found in Williams syndrome. Fifth, these patients will be having cocktail personality. Cocktail personality, over-friendly behavior is called as cocktail personality. Over-happy, over-friendly behavior, when you are too much of cocktail, too much of alcohol, your inhibition center is gone, and then you are over-talkative, talking and making friends with strangers. That type of pattern is cocktail personality. And when you look at their eyes, they have a stellate pattern, star-like pattern found bilaterally in the iris. So stellate pattern or star-like pattern is found in the iris of Williams syndrome patients. Then Treacher-Collins syndrome. Few words about Treacher-Collins syndrome. What are the key points that you should know? First of all, Treacher-Collins syndrome is found to be autosomal dominant in nature. So autosomal dominant inheritance is shown. There was an indirect question on this asked in the general pediatrics paper of INI super specialty last year. So I have not discussed it in details, but key points I am summarizing here. So I'll go a bit more slow here. So Treacher-Collins syndrome is due to autosomal dominant inheritance. The other name of Treacher-Collins syndrome, it is also known as mandibulofacial dysostosis. Mandibulofacial dysostosis. Now, what are the key features that you will see? First of all, these children will be having facial dysmorphism. So they have facial dysmorphism. So you can see that they are having anti-mongoloid slant of eyes. They have anti-mongoloid slant of eyes, also called as downward slant of eyes. What is downward slant? From medial canthus to lateral canthus, eyes are coming down. The lateral canthus is at a lower angle than the medial canthus. So anti-mongoloid slant. Second, they will have mid-face hypoplasia. Due to this, as you can see in the photograph, they are saying small flat cheekbones, which is mid-face hypoplasia. Maxillary bone will be hypoplastic. Third, they will have small retracted jaw. Fourth, they will have ear abnormalities. And when you look at their eyes, they will have colobomas in the eye. So risk of colobomas in the eye is increased in the patient. Secondly, they will have malocclusion of the teeth. Second feature I'm writing here, they have malocclusion of the teeth. Thirdly, they will have abnormal hair distribution. So hair is present anterior to the pinna. The pinna is dysplastic, but it is present, as you can see in the photograph, a lot of hair will be coming in this region in front of the pinna, which is normally not the case. Normally, It just stops here and the lower part of the pinna is here, but sometimes it can extend all the way to here, covering the pinna like this. It is also called as the preauricular hair displacement. This phenomena is called as preauricular hair displacement. Preauricular hair displacement. And the important thing to note that their IQ is found to be normal. IQ is generally normal. And fifth, they can have increased risk of conductive hearing loss. That is due to ossicular disruption. So ossicles of the ear can get disrupted, leading to conductive hearing loss in the child. So this finishes the key features of Treacher-Collins syndrome. Aquathortum, drug of choice for infantile hemangioma, is always oral medication. Topical timolol is effective in superficial hemangiomas, but when they ask drug of choice, it will always be systemic beta block, right? Topical ones will act only in superficial cases. Systemic ones, deep-seated ones, or those with extension or too extensive will not respond to topical therapy alone. When they ask drug of choice, the better answer is always propranolol. Then we have the one-liners on other syndromes. So let us do quick review of one-liners on other syndrome. There is a syndrome you can remember called as Smith-Magenis syndrome. Smith-Magenis syndrome. This is also called as 17p deletion syndrome. Also called as 17p deletion syndrome. There is a there are micro deletions occurring in small segment on 17p. It is 17p 11.2. Micro deletions occurring on 17p 11.2, which produces Smith-Magenis syndrome. And it is always sporadic. It is always sporadic. There is no inheritance which has been described for Smith-Magenis syndrome. What are the key features to remember? First of all, they have arching eyebrows. They have arching eyebrows. When I say arching eyebrows, their eyebrows will be something like this. Now, if you try to think, even Shah Rukh Khan has eyes like this, right? I'm not saying Shah Rukh Khan has Smith-Magenis syndrome, but if you have an arching of eyebrows, one of the important thing that should come to your mind is Smith-Magenis syndrome. There is an arching of the eyebrows. These days, people get arching done by cosmetic procedure. All you need is some Botox being inserted here and here, producing that typical arch in the patient. Some people like Shah Rukh Khan are born with the arched eyebrows, right? So arching of the eyebrows is the very characteristic thing. Second, they will have a flat nasal bridge. Flat nasal bridge. Third, they have reverse of what we have seen in the philtrum. They have a very short philtrum. Short philtrum means their upper lip almost touches the columella. Gap ही नहीं है यहाँ पे. It almost touches the columella. Let me make it in photograph. I'm bad at making my drawing, but it will be something like this. Can you see? It is almost touching the upper lip. That is short philtrum. Upper lip touches the columella. Columella is the lower part of the nose. This part is columella. And fourth, they have a abnormal grin when they smile. You know that they have a typical very scary kind of toxic kind of grin. That is not because of the nature, but they appear to be very abnormal grin has been described. This is how it has been described in the books. What about their mental status? IQ is normal in 50% patients, and it is low in about 40% patients. What about others? It is somewhere in between. And they have high risk of developing ADHD and self-mutilation behavior. So ADHD and self-mutilation are typically found in patients who are having low IQ-like abnormalities. So they will be having self-mutilation behavior also. And the sixth, these patients will have absence of CVS or renal malformations. So they will have absence of CVS or renal malformations. So this is the syndrome called as Smith Manganese syndrome. Rajat Sinai, decent score is, there is no such thing as decent score, but generally looking at the competition, you need to get about 80% correct after getting negative marking to get into the top 200 or so in super specialty. But again, level varies every year, and that also depends upon how others are performing and not just how you have performed in the exam. Then another syndrome that we are going to briefly discuss is Miller-Dieker syndrome. Miller-Dieker syndrome, the chromosome number. Why are we discussing this? Because Miller-Dieker is associated with lissencephaly, was one of the MCQ asked in 2022. So Miller-Dieker syndrome, it is due to LIS1 gene mutation present on chromosome 17p, and microdeletions occur in this syndrome, leading to Miller-Dieker syndrome. And what is the associated CNS abnormality in the patient? These patients are having problem of lissencephaly. What is lissencephaly? It's a migrational defect in which the smooth brain is seen. Smooth brain means the sulci and gyri are lost. Sulci and gyri are lost in the patient. And along with that, these patients also have additional findings. So hallmark is associated with CNS abnormality, not always present, but it is very specific. And you need to remember that lissencephaly can occur in the absence of Miller-Dieker also, but Miller-Dieker has lissencephaly as a very hallmark finding present in most of the patients. Even if the patient does not have obvious lissencephaly, some degree of smooth brain will still be found in these patients. Secondly, these patients have a facial dysmorphism in the form of hollow temples. So these two temporal region will be hollow. So hollow temples will be there. They have small jaw, that is micrognathia, and they have anteverted nostrils. Basically, anteverted nostrils means you can literally see the hair of these children from the outside. So the nostrils are a bit like this, right? Anteverted nostrils. And thirdly, they have low IQ, seizures, and feeding difficulties also present. So low IQ, seizures, and feeding difficulties are also present in the patient. Finally, we have the syndrome called as Wolff-Hirschhorn syndrome. The third syndrome is Wolff-Hirschhorn syndrome. Wolff-Hirschhorn syndrome. These are the patients who are having microdeletions in chromosome number 4p. And these patients are characterized by a group of features like hypertelorism. They have a narrow philtrum, very similar to the syndrome that we just discussed with Manganese syndrome. Third, they have low set ears. And fourth, they have normal IQ. And fifth, congenital heart disease seen in these patients is VSD, that is ventricular septal defect. Apart from this, there are some additional points I want to highlight. If the examiner asks you, what are the malignancies seen in a patient of Klinefelter syndrome? If you go by what the various textbooks say, the two malignancies are very commonly seen. First of all, Klinefelter syndrome patients, not just children, they have increased risk of developing mediastinal germ cell tumors. Example, teratoma. So mediastinal teratomas are very common. Secondly, they have increased risk of developing carcinoma of the male breast. So carcinoma male breast is again seen. Why am I writing as a one-liner? It's a INI super specialty general pediatric MCQ asked some years back. So most common malignancy. And from what students said, CA male breast was not in the option. So your obvious answer was mediastinal germ cell tumor like teratomas. Another one-liner related to Turner syndrome, that Turner syndrome patients who are mosaics with Y chromosome. Yes, there are some Turner syndrome patients who are mosaics. Remember that 99% patients of Turner syndrome are monosomy. 90% patients are 90% are monosomy X, that is single X chromosome, whereas 10% cases can have complex karyotypic abnormalities. One of the variant, one rare variant is the one in which the genotype looks something like this: 45XO, 46XY. This type of abnormality is there in some of the patients. So some germ cell lines are having 46XY chromosome also. These mosaics with Y chromosome, they have a very high risk of developing gonadoblastoma. And so any patient by 10 to 15 years, almost all will develop gonadoblastoma. And so these are the group of patients in which you do MCQ point. Prophylactic gonadectomy is recommended as soon as possible. Prophylactic gonadectomy is indicated ASAP. ASAP means as soon as possible in the patient. Apart from this, also remember one-liner 10 that Turner syndrome patients have increased risk of developing horseshoe kidneys. Are the horseshoe kidneys working? Yes, there is a fusion of lower pole of the kidney, but horseshoe kidneys are functional, but they in turn have high risk of developing Wilms tumor. So horseshoe kidneys are predisposed to which tumor in children? It is Wilms tumor where they are more predisposed. And then finally, a few words regarding the Noonan syndrome. Noonan syndrome, there was a very interesting question which was asked. It cannot be diagnosed by karyotyping. It is also called a pseudo-Turner syndrome. Why it cannot be diagnosed by karyotyping? Because it does not occur due to aneuploidy. It occurs due to PTPN11 gene mutations. It occurs due to PTPN11 gene mutations. And Noonan syndrome, I hope you know that the most common congenital heart disease is pulmonary stenosis, followed by HOCM, that is hypertrophic obstructive cardiomyopathy, which generally manifests after 10 years of age. So our rapid fire discussion of the syndromes is done, and we have discussed about 20 to 25 MCQs asked in past super specialty exams of last 5 years, which includes your NEET SS, which includes your INISS in this particular discussion. So I know you are supposed to read these details, and 90% things you would already know in this video, but please quickly, before you go to the exam, to 1.5x speed, have a look at it. Any additional point which you feel was missing, add it somewhere, and you would always be able to remember. And as I said, Eppert versus Cruzon, the distinguishing points, because this is also an area which sometimes gets asked in the exam. So I'm just putting it up here. So how to distinguish Eppert syndrome versus Cruzon syndrome. Eppert syndrome is generally autosomal, generally found to be sporadic. So Eppert syndrome is generally sporadic. Rarely it can be autosomal dominant, whereas Cruzon syndrome is always autosomal dominant. Eppert syndrome shows increased association with increased paternal age, whereas Cruzon syndrome shows no such association. No such association. Eppert syndrome is having brachycephaly. Cruzon syndrome is also having brachycephaly. Eppert syndrome is characterized by low IQ, whereas Cruzon syndrome has normal IQ. The hallmark of Eppert syndrome is bilateral syndactyly, that is mitten hands, whereas the hallmark of Cruzon syndrome is proptosis with strabismus. Eppert syndrome, mid-phase hypoplasia is present, plus, more severe. Cruzon syndrome, it is present, but it is not that prominent. So mid-phase hypoplasia is present. So I'm writing a single plus. Apert syndrome have increased risk of developing. They have increased risk of developing severe scarring acne vulgaris by adolescent period, whereas Crouzon syndrome have increased risk of developing acanthosis nigricans by the time they reach adolescent period. They both, all these points which I have mentioned, almost all of them are, they all are mentioned in Nelson exam, right? Of course, photographs you have already seen and you can easily distinguish between them. So Apert versus Crouzon. Question asked in exam is like this. All of the following can be used to distinguish Apert from Crouzon except. So remember this, brachycephaly cannot be used, type of inheritance cannot be used, and presence of mid-phase hypoplasia cannot be used to distinguish them. Okay. And regarding the last week important topics to focus, Sudhindra, I will be summarizing because I will miss out topics, about 30 to 35 topics collection. I will be sharing tomorrow. I also have a live session. I will be starting with it, and that PDF will also be made available. Okay. So I hope all of you do well in the exam. Time is very limited. There is no end to what can be asked. Touch upon everything. You all know about Down. You all know about SAM. You all know about pediatric neurology, seizures and epilepsies and all. Some areas which get missed out, which can make a difference if question gets asked. I have no way to know that, but based upon pattern, collection of those topics, the missed topics but are important from SS exam, that collection I will be sharing with you by this time tomorrow, right? So do well and all the very best for your upcoming exam. Keep revising. Thank you so much.